Thank you. So, good afternoon to everyone. We are going to learn about the lymphedema management part today. So, this is another nursing issues in palliative care. I know most of you have seen lymphedema in your settings. Let me share my screen. Is it visible to everyone? Can you hear us?
Paris coverage चली जा जल्दी.
Kavita, Anju, Ansi, Joyce. Punita Lakshmi ma'am is joining. So, can you hear us?
Yes, you're audible.
Okay. So, as I said earlier, we are going to learn about lymphedema management. So, before I move on to my session, I just asking, this is, we all know that lymphedema is related to lymphatic system. So, what are the functions of lymphatic system? Can anyone say? This is a part of circulatory system. So, what are the major functions of lymphatic system? Anybody? Please put your answer in the chat box. Joyce, Savida, Anju, Ansi, Beena. So what are the major, my question is, what are the major functions of lymphatic system? So, Ashwini?
No idea, ma'am.
No idea. Ashwini, you want to say something? No.
Ma'am, actually, it is it protects the body, ma'am, from the illness causing invaders.
Okay, very good.
The main function is to remove the excess fluids from body tissues. That is one function. And another one is absorption of fatty acids.
Okay.
And production of immune cells, ma'am.
Production
of immune cells.
Thank you, ma'am. Thank you. So, what is lymph? We all know that lymphatic system, throughout the lymphatic system, it is lymph fluid is moving. So, what is lymph? So, lymph is a tissue fluid or an interstitial fluid is collected through So, lymph is a tissue fluid or interstitial fluid is collected through lymph capillaries, then enters the lymphatic vessel to lymph nodes. So, it is a clear fluid. Usually, that it is collected into the interstitial space. With the help of lymphatic capillaries, we can absorb the fluids, the lymph fluid from the that interstitial space, then move the upper part of the body. So this is it contains protein and lipids and water. So this is lymph. So we heard up from Purnima ma'am about functions of lymphatic system. The first function is reabsorb excess interstitial fluid. This is the major function. So if the lymphatic system is not functioning well, so that our body function is irregular, maybe anasarca will be there. So if the lymphatic system is functioning well, there is no extra edematous area will seen in our body. And the second thing is transport dietary lipids. I'll come to that later. So in our small intestine, we have a villi. It's called that villi is functioning as a transport dietary lipids called chyle. We all know that lacteals present in the small intestine. So that is they are maintaining a transportation function, and lymphocyte development and the immune response. So these are the major functions of lymphatic system. If there is any problem in the lymphatic system there, definitely these all functions will be affected. So we all know that our circulatory system, how the circulatory system is functioning. Can anyone please explain this? So this is our circulatory system. Anybody? Savida, are you there? Nancy, are you there? So please put on your video. So I want to see you all. I need to know who all are listening the class. Thank you, thank you. So this is, can you see this screen? Okay.
Yes, ma'am. You can see the screen.
Yes, yes. Okay. Very good. So this is our circulatory system. It's anatomy. We all know that how it is functioning. Can anybody please explain? Try to explain. Nobody? Except Punita Lakshmi ma'am. Anju?
Actually, the blood supply, ma'am, which
Yes.
is, yeah, from the, as per the picture, what we can very clearly understand is from the left ventricle to the left atrium, left ventricle to the left atrium, it is again taken to the lungs and it gets oxygenated. Again, it is coming to the right atrium to the right ventricle, and it is pumped out through the aorta and to the inferior and the superior part of the body, upper and lower part of the body, through the pulmonary vein. It has again from the left atrium we can see it is coming out, and the aorta is coming out, and the capillaries of the abdominal organs and the hind organs are getting supplied. Again, it is going from here to the to the right atrium. The deoxygenated blood, it has been taken up in the blue color, which has been indicated here, ma'am.
Okay, thank you. So here we know our upper part of the body, the deoxygenated blood will be collected via superior vena cava from the upper part of the body, and the lower part of the body, inferior vena cava, the deoxygenated blood that goes to right atrium first, and then move to right ventricle. So then with the help of pulmonary artery, that will go to directly go to the lungs. So for purification, so why I want to highlight these things is there is a purification happening. Okay, with the arterial capillaries and the venous, the arterial capillaries and the venous capillaries are communicate together, and that's why that deoxygenated will get purified with the help of oxygen in the lungs. After that, once the deoxygenated blood is purified, so the pulmonary veins will be collected the oxygenated blood from the lungs to left atrium, then it goes to left ventricle, then with the help of aorta will carry all that oxygenated blood in the different parts of the body. Okay, so again branches, we all know that. So I want to highlight here what the major thing is. Okay, sorry. So here also the lower part of the body is also the arterial capillaries and the venous capillaries is communicate together. So here you have you can see that venous system and the arterial system. So venous system is you have seen in the blue color, and the arterial system is red color. So here is the oxygenated blood, this is the deoxygenated blood. No, so here so when the arterial capillaries and the venous capillaries is communicate together, so there is a chance of moving out of fluid into the tissues. That fluids will be absorbed by the lymphatic capillaries. You can see that green color, that picture. So that is the lymphatic capillaries. Okay, so that lymphatic capillaries overlapping to the endothelial cells, it has a blinded wherever the fluids will be drawn with the whenever the arterial capillaries and the venous capillaries will be communicating, that time definitely the oozing out of fluid will be there. That time the lymphatic capillaries will be absorbing the extra fluid from the interstitial space. Okay, is it clear to everyone?
Yes, ma'am.
Okay, so then you can see what is lymphatic capillaries. So as I said earlier, it has a blind end and a thin layer. Okay, so single layer of overlapping endothelial cells and more permeable than that the blood capillaries. This is a thin layer wall, so it is more permeable than the blood capillaries. So that is why if there is an extra fluid in the interstitial space, that lymphatic capillaries will be absorbing freely from the interstitial space. So coming to the lymph nodes, so it has a small round or oval shape. It's located along the pathways of lymph vessels. It's around 600 to 700 lymph nodes in our body. That length is 6 to 25 millimeters size. So typically found in clusters, received in lymph from the many body regions. We all know that from the interstitial space, that lymph fluids will be collected from the lymphatic capillaries. Then it goes to lymphatic vessels, and again lymph nodes, then again lymphatic vessels. Then finally it has drain into the subclavian vein. Again, that fluids will be in our the circulatory system. Okay, so lymph nodes are also found in individually throughout the body of the tissues. So when the lymphatic capillaries absorb the fluid from the that interstitial space, it's directly go to the lymphatic vessels. Then again lymph nodes. We all know that lymph nodes. That usually lymph nodes are in our body that throughout. I also mentioned earlier. It's around 600 to 700 lymph nodes in our body. So this is a concentrated, the lymphocytes, usually within the lymph nodes and the spleen and lymphoid tissues, like tonsils, spleen and lymph nodes is concentrated in the lymphocytes. So it is the response that usually the immune response against the foreign pathogen is usually happen in the lymph nodes and spleen and tonsils. These are the major lymphoid organs. Then after after that fluids, it goes to lymphatic vessel, again lymphatic trunk, collecting trunk. So after that it goes to subclavian vein. This is the pathophysiology of lymphatic system flows. So what is lymphedema? So we all know that where the lymph origin and where it goes. Okay, from the lymphatic capillaries, it goes to subclavian vein. Okay, so that is why we call it as this is also is a part of circulatory system. After from the collecting duct, it goes to subclavian vein. Okay, so what is that lymphedema? If there is a lymph node removal or any damage, if there is in our lymphatic system, if there is any damage or any lymph node removal happens there, that function is stopped there. No, so that time there is a chance of developing edema in that particular part. That is lymphedema. It is the swelling of interstitial tissue as a result of lymph drainage failure when capillary filtration is normal. If there is a capillary filtration is normal, definitely there is a chance of oozing out of fluid into the interstitial space. So if there is a block or any damage or removal of lymph nodes in our body, that fluid will be retained there. So that fluid will be collected there. So that is called lymphedema. So according to the International Society of Lymphology, is classified two types. First is primary, the second is the secondary one. What is primary? Primary is the congenital, the lymphatic dysplasia. From the beginning, the birth itself, there is a damage that damage of or poor development of lymphatic system. That birth itself, there is a problem. So that is primary lymphedema. The secondary is anatomical obliteration of the lymphatic system. So that we all normal today, but tomorrow or day after tomorrow, we don't know what is happening in our body. If we develop such problems in our body, definitely, for example, if I will develop, if I develop a cancer in my breast, definitely I not need to undergo a surgery. Okay, so I need to remove my breast. When I remove the breast, definitely they will remove the adjacent lymph nodes. So if they remove adjacent lymph nodes in my axilla, definitely I am the best, maybe I am the risk person is to develop lymphedema. Okay, so that is if there is any change in our existing the lymphatic system there, so that is secondary lymphedema. So again, that secondary lymphedema called divided into two: non-malignant and malignant. So non-malignant is trauma. So any road that traffic accident So that time, if we if the patient is damaged the major lymph nodes in there, that groin area or axillary area, there is a chance of lymphedema there. And infections, recurrent infections like cellulitis and hydrogenic surgery, radiotherapy. So as I mentioned earlier, if I undergone any surgical or the management in my body, definitely I am the person to develop lymphedema and radiotherapy. So if you take a radiotherapy, definitely that lymph nodes will be damaged and that person is also develop lymphedema. Come to the malignant part, primary is the lymphomas. If the cancer is developed in the lymphoma, that lymphocytes, that lymph nodes itself, that person is develop lymphedema, and secondary is recurrence. It can be spread from the one part to the another part, that is there's a recurrence. So this is the classification, secondary classification of lymphedema. So how to diagnose lymphedema? We all know that all edema is not a we need to understand that all edema is not a lymphedema. So we need to diagnose. So how we can diagnose lymphedema? You have to take a good history. So what are the things we need to do, that we need to take during the history taking? So is there any unknown cause? So we need to find out that. And is there any disease or trauma related? So maybe previous disease, maybe recurrent infection there, or that maybe road traffic accidents, maybe major accidents is there. So you have to find out that. And treatment like surgery or chemotherapy or radiotherapy. So these all things you have to find out. And along with that, you can, after you have to take a history taking, then you can do the clinical examination. So how can we do the clinical examination? There are 3 stages of lymphedema. The first stage is pitting edema stage. Okay, so in this stage, you can apply gentle pressure on that swollen tissues there. You can see your finger pressure on that area. Okay, so that is the stage 1. You can able to manage with the help of small, if you do the small muscle. If you do the, if there is a pitting edema stage there, if you, there is that skin will be soft, you can able to manage with your small massage. So I'll come to later what is that manual lymphatic drainage, what is simple lymphatic drainage. We can train the patient as well as the caregiver for managing lymphedema. So coming to the second stage, sorry, here some work is going on, so that is why that sound is coming. The coming to the second stage, the tissue have become fibrotic and hardened, and the tissues are no longer soft. So if you treat the first stage edema, you usually the tissues will be, that area will be fibrotic and hardened. We are not able to manage well, but somehow we can able to manage with the help of the massaging and bandaging, multi-layer bandaging, multiple layer, like figure of eight bandaging. We can able, if you give that type of bandaging there, we can able to reduce that edema in second stage. But if you second stage also you not give adequate treatment for that patient, definitely the tissues will be hard, and we are not able to manage well. So that is stage 3. So how will we manage? So again, one more that sign is there, stemmer sign. Can you heard about, anybody heard about this name, stemmer sign? So stemmer sign, only sign which we have seen in lymphedema patient. So in our legs, if the patient is developing lymphedema in the lower legs, so we cannot able to pick up the fold of the skin on the over the proximal phalanx of the second toe. Okay, so this is the identification of lymphedema in the lower limbs. Okay, if the patient is having lymphedema into the lower limbs, so we are not able to pick up the fold of the skin over the proximal phalanx of the second toe. So this is the identification of the management of the lymphedema in the lower limbs. If the patient is having upper limbs lymphedema in the middle finger, we are not able to pick up the fold of the skin. Okay, so you have seen in the picture. So if there is no edema there, we can able to lift up the fold of the skin on the middle finger or in the lower legs, we can able to fold the skin over the proximal phalanx of the second toe. But in case of lymphedema there, we are not able to lift up the skin. So come to the skin changes. There are three changes in the first stage. As I mentioned earlier, there are three stages are there. The first stage is pitting edema stage. It looked like an orange skin peel. Okay, so that is stage 1. And the second stage, I already said, the tissues become hardened, no longer soft. Okay, so that sometimes deep creases will be there. Sometimes it may not be there. And the third is hard skin. Okay, sometimes it will develop if that particular part develop any infection there, cellulitis also happen in that part. So what are the other diagnostic methodologies? So one is soft tissue imagining, MRI and CT, you can do that. So if you do that soft tissue imagining, you can able to determine extra fluid volume. Okay, and lymph vessel imaging, so you can able to detect the abnormalities. And the third one is bioimpedance spectroscopy. You can able to measure the interstitial fluid volume again. So here in palliative care, we don't do these all things. We usually take the proper history and do the clinical examination. And in case of primary lymphedema, if there is a that primary congenitally abnormalities there, from the birth itself, if we see these type of problems, edematous area limbs there, you can able to do all these things, and you can from that part you can able to detect whether that the interstitial space have extra fluid volume or if there is any abnormalities there, we can able to find out. Okay, but usually in palliative care we can't we are not do these all things. This is quite expensive. So you can do the proper history taking, and from that part you can able to find out whether the patient is having lymphedema or other edema. So what are the other conditions that patients might have developed edema, especially in the lower limbs?
Renal problems, ma'am.
Renal problems, very good. So if there is any renal problem, and the another thing is any COPD, that's respiratory related problems there, usually the patient is developing the facial edema and all. So usually the renal problems there, the patients will develop angle edema, the pitting edema will be there. So you have to take a proper history before you that come to the diagnosis. So we all know that the problems. So lymphedema, you can just imagine one limb is normal, the another limb is huge because of fluid, accumulate fluid on the one limb. It can cause, they are not able to lift their limbs freely. So they need to depend others for any help. So that all things will be affecting the persons physically and psychologically, especially. So pain and discomfort will be there. Okay. So because there is a lot of fluid volume into the interstitial space, the tissues stretching as much as possible, but after that, the patients will getting pain. So that patients will be developing pain and discomfort also, and impaired mobility. If there is an impaired mobility there, so they need to depend others, and loss of functions. They are not able to move their function, that limbs freely. So it has affect physically. And the move on to the psychosocial part, body image. Just imagine one limb is normal, the another limb is huge. So that is affected, that will be affecting the patient psychologically. Okay. And loss of independence. So even the small things also, if they want to take a maybe things from the cupboard, so they are not able to, maybe upper that upper part of the cupboard, so they are not able to use their one limb. They need a both limbs. So that time they need to depend others. So loss of independence will be affecting the patient psychologically, and loss of change or employment. So this is also very, very important. So this is, you just imagine, we are all nurses. Okay. If we develop this type of illness, that organization or that hospitals put that our duty in the office department or maybe other works. How do you manage, and what all things in your mind? So how will you cope up with that situations? So this is very, very that problematic. And if they change in the routine works, definitely that will be affecting psychologically and spiritually. And difficulty in wearing clothes and shoes. So they are, if they want to wear a shoes, they may be shoes and clothes, ready-made clothes. So we know that both that limbs normal, that same only. So so they are not wearing that clothes, the ready-made clothes and shoes also. If the patient is having lower limbs lymphedema, they are not able to wearing the shoes. That also affect the patients emotionally, and anxiety and depressions. So day by day, the lymph volume, the lymphedema is increasing, and so after that, the lymph size is that size is enlarging. So that will be affecting the patients psychologically and spiritually. What is going to next, and gradually, if they treat well, if they are not treated well, definitely there is a chance of lymphoria there. So there is a there's a chance of crack into the lymphedema area and oozing out of lymphatic fluid from the lymphedema site. That is also happening there. So you, if there is an anxiety there, if you're not treated well, the patients will go to depression stage. So we have to find out whether the patient is having any anxiety about their disease conditions. If there is an anxiety there, you have to give a proper explanation to the lymphedema management. And social isolation. So here also social isolation, the society will not be accept this type of patients if the patient is having lymphedema. Though usually that will be they might be thinking maybe misconception of this illness, that oh, that patient is developing cancer. So we know cancer is there, but lymphedema is a part of that because of the damage of lymph nodes or any removal of lymph nodes there, definitely the lymphedema there. So they may that patients or the society people might be thinking, okay, that cancer is spreading on their limbs too. So that type of thinking will be there. So society will be isolating this patient, this type of patients, and constant reminder of disease also there. Usually, if there is a lymphedema, swelling is increasing, the patients might be thinking my disease is spreading from the breast area to my limbs, like that. So you have to give a that proper explanation for that. So if you listen the problems clearly, definitely you can able to find out those problems. If they have these type of problems there, you can give a special attention for that. So come to the management part, we can able to manage four that parts. So one is skincare. So that part you can give a proper education to the patients. What all things they need to keep it in mind if they have a developed lymphedema. So that is under skincare. And massage. The second thing is massage. We can do the simple lymphatic drainage. We all know that there is a blockage into the lymphedema, that lymphatic system. We all trying to move their fluid, that lymphedema fluid, from the affected part to the non-affected part. So we can try to move the fluid from the affected side to the non-affected side. So that is the massage part. Again, you can do the compression bandaging. Okay, after after you can do the massaging, you can do the compression bandaging. So after that, if you do the compression bandaging, then you can train the patient to the exercise too. Okay, if you after you do the bandaging, you can, if you do the exercise, definitely the collected fluids will be moving to not that affected areas. And intermittent pneumatic compression pumps also we can use for manage. So before you can move do the massage, you have to measure the lymphedema area. So how we can do the measurement for the upper arms? One is before you can do the measurement, you have to give a comfortable position to the patient, and the first measurement should be from the that ulna, from the tip of ulna plus 2 centimeter. Okay, then from there again from there every 4 centimeter. Okay, first you can mark it that point, then you can do the that measurement on that area. So you can do the unaffected and the affected limbs. Then only we can able to find out that how much edema is developed in the affected edema. So we can able to you can differentiate from the normal lymph and the affected lymph. So how will we take a lower limbs measurements? Again, you can do the give a comfortable position to the patients. From here, you can do the medial malleolus plus 2 centimeter. Okay, you can point out the medial malleolus plus 2 centimeter. Then again every 4 centimeter. You can just mark it down there first, and then you can do the measurement. So skincare. Skincare part, always you have to educate the patient about say that application of moisturizing cream. If there is no moisturizing cream, Vaseline or any white petroleum jelly or any like a cream is not available, they can use coconut oil for applying on the skin. So I apply moisturizing cream is important. Keep the skin clean and dry. Always they have to keep the skin clean and dry, especially between the digits. So that between digits, if there is a chance of dirt accumulated in between the digits, so it can cause fungal infection. So you have to give a special attention on that area. Avoid injections or venipuncture. That affected limb, you don't give any injections and venipuncture also. Avoid blood pressure cups also. If there is an injury there, try to avoid injury. We know, so there is no lymphocytes or lymph nodes in there, that part. So if there is a cut there is a chance of developing infections like cellulitis. So if there is try to tell the patient to avoid prevent injury. If there is an injury there, they can keep it clean and dry. If they develop the signs of infections, maybe inflammation, the signs there, definitely they can seek medical attention. And avoid carrying heavy things. So these all things you have to educate the patient. So if they take heavy weights in their that affected limbs, what happened is that arterial the circulation will be increasing. So if the arterial capillaries and that venous capillaries is that blood circulation is increased, definitely there is a chance of accumulation of edema there. So try to avoid carrying heavy things. So come to the massage part. There are two different types of massage there. One is manual lymphatic drainage. The second one is simple lymphatic drainage. So manual lymphatic drainage is, you can do, one of the trained persons will be doing that manual lymphatic drainage. So simple lymphatic drainage is the patient or the caregiver will train the lymphedema massage, and that patients will be doing the massage. That is simple lymphatic drainage. So usually the manual lymphatic drainage is usually done by the trained physiotherapist or a trained nurse. So how we can do the massage? Start and end up with a deep diaphragmatic breathing. So this is very, very important. So start and end with the deep diaphragmatic breathing. So I already said there are 600 to 700 lymph nodes in our body. If you take a deep diaphragmatic breathing beginning before starting the massage, if you move the fluid from the affected area to the non-affected area, all lymph nodes will be ready for collecting extra fluid from the non-affected part. So, okay, so from the affected part, sorry. So the affected lymph nodes and the region of the body are treated first. This is very, very important. You have to stimulate massage the affected areas to the not affected area. So unaffected lymph nodes, that means if the patient is developed lymphedema on their left arms, you have to stimulate the unaffected the right lymph node, right axillary lymph nodes. Okay, and the idea is when we push the fluid, when we push the fluid from the affected part to the non-affected part, that lymph nodes should be ready to collect the extra fluid from the affected part. Okay, so that is why before we moving to the affected area fluids, you have to stimulate the unaffected lymph nodes. Okay, you can stimulate the periauricular area the supraclavicular nodes and unaffected axillary lymph nodes. Moves proximally to distally. Okay, always you have to try to move the fluid from the proximal area to distally. Okay, first you have to clear the proximal part, then you can move on to the distal part. Okay, our idea behind this, you have to push the fluid from the affected part to the non-affected part. So when we do this massage, you have to do it as a slow and rhythmical movement. Use gentle pressure. If you give more pressure on that area, definitely that arterial circulation will be increasing. If the arterial circulation is increased, definitely there is a chance of edema there. So profound edema will be there if you use it good massage on that area. Your gentle pressure is enough to move the fluid from the interstitial space. So this is the manual lymphatic drainage. You can see that the lymphedema, that green color. So there are a lot of lymphatic fluid lymph nodes in the area. Green color you can see. So try to stimulate that visible superficial lymph nodes like periauricular lymph nodes and submandibular lymph nodes and supraclavicular lymph nodes. You try to stimulate that. So, that patient is and the caregiver doesn't know where all the lymph nodes is there. So always the trained physiotherapist or a trained nurse should know where is the lymph nodes and how to stimulate lymph nodes. Always you have to stimulate the superficial lymph nodes before you can do the that affected area massage. Then you can do proximal to distal massage. After stimulating the superficial lymph nodes, you can do the massage from the proximal area to distal area. You can clear the proximal part first and then goes to the distal part. So some of the contraindication there. If there is a patient is having, if the patient is having a history of congestive heart failure there, so that patient is contraindicated for massaging, because if you push the extra fluid into the area, if there is a heart failure or respiratory failure there, so there is a chance of breathing. If there is a breathing that respiratory failure patient there, so there is a chance of breathing difficulty because that extra fluid volume is coming up, that that person is not able to manage their organ, that heart or a lung is not able to manage that kind of extra volumes. So that person is contraindicated for massaging. And acute inflammatory caused by pathogenic germs like bacteria, fungi, and virus infection. Like, say, if there is a cellulitis there, that patient is contraindicated for massaging. So after you treat that cellulitis part, you can do the that massaging. Then acute renal failure. Again, if you do the massage this type of patients, that because of the fluid volume, increased fluid volume, there the renal the kidney is not able to push the extra fluids. Again, there is a chance of renal failure and acute deep venous thrombosis. So these are the contraindicated patients for massaging. So before we move on to the bandaging part, I'll show you a video on massaging. This is that old video. Nowadays, this video is having that the nurse will be applying the oil before doing the massage. The nurse is applying the moisturizing cream on their body. But now the literature and studies said the application of moisturizing agent before massaging is contraindicated, because if you apply pressure on that area, the fluid will not be move freely. So we need a friction. We need to put a small friction on that area. So before doing the massage part, you should not apply any moisturizing agent. But all other steps are normal.
Management of lymphedema. Part 1. Rama is suffering from breast cancer and has developed lymphedema on her arm. Greet the patient and caregiver. Explain the procedure to the patient and caregiver and
Thank you. I hope all of you get that this idea about how to do the massaging. So then now we move on to the bandaging part. Initially, you can do the spiral bandaging. Before you put the bandaging, you can cover the area with a that cotton roll. So sometimes that crab bandage will be allergic to the patient skin. So if so, that for that precautions you can do. What you can do is you can we apply a simple layer of cotton, or you can make a dressing pad like that and roll up dressing pads, and then you can wear on the affected limb before applying the crab bandage. So initially you can do the spiral bandaging. If the patient is that managed, maybe if the patient is tolerating the spiral bandage, that first initial 2 weeks, you can do the multi-layer bandage. Okay, so multi-layer bandage is finger of 8 bandage. So our idea is, if you do the multi-layer bandages here in the lymphedema site, because of the pressure of the lymphedema multi-layer bandage, that the fluid will be pushing from the affected area to the non-affected area. So after you can do the bandaging, you can do the exercise part also. Similarly, you can do the bandage is the same thing. You can you do stockings will be compressing the circulation. So that's why we should be removing the compression bandaging. That compression bandage means that sleevings. If they are using sleeves, compression garments like that stockings, there they can remove during the night time. There no need to remove the bandage, the crab bandaging. So crab bandage, if the edema is reducing, the swelling is reducing, the crab bandage will be loosened. So coming to the exercise part, you should do the educate the patient gentle and regular exercise and prevent stiffness. So that way we can able to prevent stiffness. So encourage normal activities. Some normal activity you have to encourage the patients, not a exercise like major exercise. No, they are not do the weightlifting, heavy weightlifting on their affected limb. They can do the small exercise and range of motion exercise and passive and active exercise. If the patient is able to do the exercise, you can encourage the patients. But usually the patient is having lymphedema, they are not able to do the exercise independently. That part, that nurses or the caregiver should be doing. You can educate the caregiver for the same. So the another management is intermittent pneumatic compression pump. We all know that. I think some of you have seen this. This is a electrical air compression pump attached with the inflatable plastic garments that is placed over the affected limbs. If the patient is having lymphedema on the lower limbs, you can see that picture. So that patient is lying down in the flat surface, and that machine, that compression garments is put on their affected limb, and so after that they can that put a measure on that pressure on that. Usually we can start with a 30 to 60 high G pressure and over duration 30 to 120 minutes. If the patient is having stage 1 lymphedema there, you can suggest for this that intermittent pneumatic compression pump. If they that second stage and third stage lymphedema there is not advisable. And the another thing is if the area is hot and if the patient is having any distress during the intermittent pneumatic compression pump there, you can stop the intermittent pneumatic compression pump. So that is the management of intermittent pneumatic compression pump. If the patient is having stage 1 lymphedema, you can suggest for this. So we can see some of the complications of lymphedema. One is cellulitis, acute inflammatory episode. If there is a cellulitis there, you can refer the patient to the physician and make sure that the patient is taking an antibiotics for that. So after that, you can, if there is a cellulitis there, you should not apply any that crepe bandage or you should not do massaging on that area. If there is a cellulitis there, definitely the patients will develop pain also. So you can treat the patient's pain as well as the infection. So after relieving the infections, you can do the massaging and bandaging. The next complication is lymphoria. So leakage of phlegm from the edematous lymph. If you are not treated the lymphedema well, there is a chance of lymphoria there. So here you can do one thing, that edematous, that lymphoria site should be covered with a dressing Gamgee pad or a dressing that pad, and then you can apply crepe bandage so that all excess fluids will come out easily. Okay. So before taking the questions, I'll show a video on compression bandaging, and then after that I'll take a few questions. Then any questions there, you can just ask.
Hello, ma'am.
Marinia?
The bandage size you can still repeat again, ma'am. For the fingers, what size we can use, ma'am?
Sorry.
For the fingers, what size we can use, ma'am? 6 inch and 8 inch.
Yeah, so we usually we have received 6 centimeters bandage. We can fold it into 2. Then you can yeah, 2.
Okay, ma'am.
Then you can use that bandage for the finger.
We can fold it and keep, no, ma'am.
Yes, fold it.
Okay, ma'am. Thank you.
Yeah.
Okay, ma'am.
So any other questions? So if you don't have any questions, we can move on to the case presentation. Is that case presentation? So Ms. Miriam will be presenting the patient story today. Miriam, are you there?
Yes, ma'am.
Yeah.
Am I audible, ma'am?
Yes, you are. Let me share your slide.
Yes.
Wait. Are you able to see?
Yes, yes.
Wait. Slideshow. Slideshow ആണോ?
Yes, yes. Good evening, everyone. I'm Miriam, staff nurse from Mizoram. Now let's move on to my patient. My patient is 56 years old and she's female and she's diagnosed with cancer of the right breast. Her presenting complaint is pain at the right breast, which is radiate at back, and fever, and then redness, discharge, and tenderness at the right breast. History of illness is my patient complains of pain at the right breast, radiated at back since 2 months, fever and discharge from the breast since 1 week, and weight loss, loss of appetite, and insomnia. Physical examination was done for her, and under physical examination, weak and pale, and she has weight loss, and assessment of breast is done again. Her right breast is increased in size, and redness, tenderness, and discharge is there, and unpleasant smell is also there. Treatment and significant investigation was palliative care, hormonal therapy, wound dressing, nutritional support, and analgesic. And medication was hormonal therapy, anti-cancer drugs, and tablet paracetamol was given for her as well, and tablet morphine according to WHO letter, and metronidazole, and tablet alprazolam 0.5 mg. Her psychological aspect is shock, denial, panic, anger, loss of control, low self-esteem, and fear of pain. Her main concern is pain management and low self-esteem, as well as odor at the site of wound. Let's summarize. A 56-year-old woman diagnosed with cancer of the right breast with redness, tenderness, and discharge from the site associated with unpleasant smell, management done along with addressing the psychological issue. For our discussion point, do we need palliative care for this patient? What all things can be done to manage discharge and odor of wound? And what can be done for pain? Thank you.
Thank you, Miriam, for the excellent presentation. So anybody need any clarification regarding this patient story? Okay. So we can move on to the discussion points. So the first question is, do we need palliative care for these patients? I'll expect from the participant side to answer this question.
Ma'am, we don't know exactly first stage or second stage, ma'am.
Actually, it's second stage.
Then I think so. She don't need palliative care.
Yes, yes.
Okay.
So why do you say that second stage or first stage? That then you say the second stage, the patient needs palliative care. What about first stage?
Yes, actually, for first stage also we need palliative care, but during my case collection, she is already in her second stage. So from first stage also we need to do palliative care too.
Yeah, my question is to Condia sister. So why do you say the second stage?
Ma'am, second stage, doctors will give chemotherapy and radiation, surgery, everything they can do, and they will improve a lot, ma'am.
So when will we start palliative care?
It is going to be the first stage, ma'am.
Okay. What about others? So when will we start palliative care?
Ma'am, it
From the
is
start of
from the,
diagnosis,
yeah,
from
from the
starting of
starting time
diagnosis.
itself. When the patient goes with some problem or the diagnosis done, from there itself the palliative care starts.
Yes, yes, yes.
So from the point of diagnosis, we should give palliative care for that patients. Along with the curative treatment, you have to give a symptomatic management and supportive
Yes.
care. So that is
Yes,
the palliative care. So from this day onwards, you should keep it in mind. You can start the palliative care from the point of diagnosis. Okay.
Yes,
So
yes.
yeah, definitely, we all agree these patients need palliative care. So the next second question is, what all things can be done to manage discharge and order of wounds? So we heard on session on fungating wound management 2 weeks back, I think. So how will we manage if there is a malodor or a discharge coming from the wound? So how will we manage that types of wounds? Anyone? It's very bad. We had 2 sessions. One is on wound management. We had 2 sessions. One is pressure sore. The second one is fungating ulcer management. So that time we were discussing how to manage the fungating wounds, pain, malodor, oozing, bleeding, and maggots. So my questions to you all: how will we manage fungating wound, especially if there is an exudate wound there? How will we manage? Anybody? Please put your answer into the chat box. Answers. Please put your answers. If there is a discharge from the wound, there is a exudate from the wound, how will we manage? Usually, the wound management will be done by the doctor. So, how will we manage this type of wound?
You can use metronidazole, ma'am.
Yes. Can you repeat?
You can use metronidazole, ma'am.
We can use metronidazole. Very good. Then, what about others?
Dressing with charcoal, calm dressings.
Very
Like-
good.
And that we can use, ma'am.
Ma'am, daily
Daily dressings. Very good. We can do
dressing,
daily dressings. Then,
clean every day. Yeah, clean.
clean every day. Clean the wound every day with normal saline. Then,
Yes.
apply metronidazole. So there are 2 major causes of that malodor coming from the fungating ulcer. That is one is because of stale exudate dressings have been more than placed in number of days. That is the one cause. The second cause is anaerobic bacterial infection because of the maybe that necrotic tissues, the necrotic tissues in their wound. There is a malodor coming out. There is a chance of malodor coming out. These are the 2 major cause of malodor developing from the fungating ulcer. So the management is, you can do the cleaning and dressings with normal saline. The second thing is metronidazole applications. So metronidazole is a good agent for controlling anaerobic bacterial infections. The drug of choice of controlling anaerobic bacterial infection is metronidazole. So you can apply metronidazole for that. Then you can apply charcoal dressings. So charcoal is the good agent for absorbing malt odor. So charcoal dressing is available, but the thing is too expensive. If the patient is affordable, you can that advice for that. So if the patient is not affordable, you can use 1 or 2 pieces of charcoal. The charcoal you can make it in your home itself. So that charcoal pieces is also you can use for absorbent of bad odor. You can keep 1 or 2 pieces in the corner of the room or under the bed of the patients. That will help to remove the malodor. So these are the ways we can able to remove or reduce malodor. And discharge, how will we manage discharge? If there is a exudate, huge exudate coming out from the wound, so how will we manage? So this is very important. The patients will be panicked. They will be anxious about that. Where does it come? That lot of fluid from the wound. So it is very difficult to manage ourselves and that patient itself. So that we need to give a proper management for that exudate. So what you can advise is, you can advise instead of 1 or 2 Gamgee pad, they can use multiple layer of Gamgee pad. If there is an exudate there, they can use maybe 3 or 4 pieces of Gamgee pad at a time. So that we can able to reduce the frequency of dressing changes. Okay, if you do the frequent dressing changes also, the patients will be anxious. So that way, if you do this way, we can able to reduce the duration of dressing changes. And another option is the napkins, the safety napkins you can use for the dressings. After dressings, you can apply 1 layer of Gamgee pad. After that, you can cover the wound with the safety napkins. That will be that is the good that fluid absorbent. So that will be helpful for this type of conditions. Okay, so this way we can able to manage. And the next question is, what can be done for pain? So these questions answer I expect from the participant side. Again, we had a session, 2 session on pain management. One is NSAID, NSAID and weak opioids management. The second one is opioid management. So how will we manage this patient? Yes, sister.
Local xylocaine we can apply, ma'am.
Local?
Xylocaine.
Local xylocaine. So when will we apply local xylocaine?
Before doing dressing, ma'am.
Yeah, so we need to find out whether the patient is having any pain on the before dressing, right? If the patient is having pain on their that wound part, so area, you have to assess whether the pain is neuropathic or nociceptive. If the patient is having nociceptive pain, you can give a systemic analgesis. For example, the patient is on morphine 4 hourly, you can give an extra dose of morphine. Okay, you can give a rescue dose of morphine and wait for 45 minutes, and then you can do the dressings. That time the patients will get adequate pain relief. If the patient is having neuropathic pain, your systemic analgesics may not help. So that time what you can do is, you can apply local anesthetic agent like xylocaine or sensocaine. You can take 1 ml of xylocaine or sensocaine and pipivacaine. Sensocaine is pipivacaine, and dilute with again 1 ml of normal saline and just spread on the wound. just then within 10 minutes, maybe that patients will get pain relief, like local anesthetic effect on that particular that area. Then you can able to do the dressings. That is the management of wound pain. Okay, so here, where is the pain, sister? That Mr. Media?
Yes, ma'am. Yes, ma'am.
Yeah, where
It's from the wound side. Yes, from
the wound side
wound.
only. Okay.
Yes.
So, what is the dose of morphine the patient is getting? Vidya? Yeah, here you have,
Yes, ma'am.
you have mentioned tab morphine according to WHO ladder. So, what is the dose of morphine the patient is getting right now? Is that patient is on morphine?
Ma'am, I think it's 4 mg.
So, sorry?
Hello,
Yes.
ma'am.
Ah,
Yes, it's 4 mg.
4 mg injection or tab?
It's tab.
4 mg tablets is available there. Usually we will get 5 milligram, 10 milligram, 50 milligram
Oh,
strength.
yes. It's 5 mg. Yes,
It's 5
5
mg.
mg. Yes.
Okay, so this patient is on tab morphine 5 milligram, right?
Yes.
Uh, so what you can do is, you can, before dressings, you can do one thing. You can assess the patient pain, what type of pain the patient experience.
Uh, she said it's very painful.
Yeah,
So
so what you can do is, you can do the
from the
proper
wound side,
assessment, for the patient's pain.
yes,
So whether the patient
yes,
is having neuropathic pain or nociceptive pain, you have to find out that. So based on their assessment, you have to treat. So as I
yes.
said earlier, you can do that one thing. If the patient is having that nociceptive pain, you can do that. Give an adjacent, then maybe systemic analgesics like morphine, rescue dose of morphine
Yes,
you can give. Or if the patient is having neuropathic pain, you can do some that local anesthetic agent like silocaine or sensorcaine.
yes.
So what about that the patient's sleep?
Uh, can you repeat that question again, ma'am, please?
Sleep. What about sleep? Is that patient sleep is normal, or is there any problem? The patient is getting
Yes. She can't sleep
ultrasonography.
at night. Yes. She can't sleep at night. That's why tablet alprazolam 0.5 mg is given to her. One tablet.
Okay. So what about the family history?
Uh, like for family history, like mm, she's having three children, and then her husband is also there, and there is no history of cancer from her family. I've asked her, and she told me that there is no cancer history from her family.
Okay. So you have to find out why the patient is not sleep well. So you have to identify the cause of
Yes,
insomnia. If there is a
yes.
psychological problems there, if there is a psychosocial issues there, definitely that will be affecting their sleep. So you have to
Yes, yes.
find out. And the another thing is, if the patient is having pain, the patients won't be able to sleep properly. So you have to find out what is the main problems behind that. So based on
Yes,
that, you
yes.
have to try to relieve their problems.
Yes,
So,
ma'am.
anybody want to contribute anything for this patient story? No. No question? So if you don't have any questions, we can wind up the sessions. Okay. Thank you. Thank you everyone for attending the sessions. Thank you, Vindiam, for the excellent presentation. Thank you for.
Thank you, Sheeba ma'am, for this wonderful session. I think this was a beautiful, this was the most wonderful session, and everybody uses it very well. And hope to see all of you on the next section. Thank you all, and kindly please send your feedback. Please share it. The link is already shared in the chat box. Thank you all once again. See you again. Bye bye.